Okay, so welcome to anatomy and physiology and common injuries that clients may face. So, in my experience, it's always a good idea to do movement screening when you're with clients that can kind of flag up these kind of things. It's always good to be able to understand how a person moves as well, because there will be differences person to person. So it is great to understand that by having a screening process in place before you actually start giving loaded exercise. But it can be quite often that a person may already be doing something and they don't even realize that they have an issue until it occurs. And that's commonly where they'll then point out, oh, this kind of hurts me when I do this, or this is sore when I do that. And that's where we might have to then pick it up from a A&P perspective and try figure out solutions. So, as I said, I'll try cover some of the common ones that I've came across, mostly with the major lifts, and then you can then ask questions on that afterwards. And if you have any of your own that may pop up, then please feel free to ask at the end as well. So, the first common exercise you're going to do with a client will probably be a squat. And there's so many factors to squats that we have to consider to make sure that the person is comfortable, can get proper depth, can even then eventually add more load if needed, and get to the goal thereafter. So if we think about the breakdown of a squat and what mechanisms are going on, there is so many things that can possibly take place. So we'll look from the bottom and then run up the train. So what we have most commonly will be ankle wobble. Now, from a A&P perspective, it depends on which way the ankle wobbles that you can then make an assumption of what might be going on. So, for instance, if the ankle buckles outwardly, so you see it move to the outside of the body, that could be that the calf might be tight on that side and it is pulling on the ankle, and that's why it pops out to the side. It's getting pulled on, it's the force as you go down. Or it could be that it buckles inwardly. Again, that's going to be another common factor of a tight calf. It could even be tight hamstrings, tight glutes, but again, you would move up the chain to kind of see where that is if the calves weren't tight. And then there's the other common thing, which is flexibility of the ankle. Now, flexibility wise, it might be poor, and a lot of the time that could be because of a job that a client may do. So they might sit at a desk, their ankle flexibility has gone over the years, and now you've got them squatting quite deep. Their ankle flexibility just isn't there anymore. You can't really see the flexion. It's almost in an upright position. So if we are looking at ankle movement, we're looking at the flexibility forward and making sure that there's no flexibility at either side. So angles of the ankle versus the shin bone, and then the body versus the shin, if you can imagine that, the shin and the body should be almost in line with each other, parallel. And if the body is not and it's fallen too much forward, that could be an indication of ankle flexibility being poor. If the ankle flexibility is poor, then a quick solve for that would be to put a couple of plates underneath the person's heels. That'll elevate the ankle and allow you to flex forward in the shin bone area, but it won't solve the problem. That is a mobility problem, and they will have to then go and do ankle mobility stuff. You might have to use bands to increase mobility of the ankle. You may need to use some other manual therapies. There could be a whole host of things you'll do there, but again, something to keep an eye on. Then moving up the chain, we've then got the knee. So the knee suffers from the same pull aspects as the ankle might. The knee might buckle in, it might buckle out, it might also have pain. And you'll probably have seen the little diagram I put up on Instagram earlier today, or on the Facebook group. And it showed you the VMO, the vastus medialis. And that is probably, in my own professional opinion, 99% of the time the problem with knees. Now, if they've had a prior injury, then of course that's going to be the usual underlying problem. But the VMO is a tiny muscle. They call it the teardrop muscle. And what happens with it is it gets tight. And it's very easy to press on the trigger point on this area, and for 99% of people to have pain in it. Now, when you have a trigger point pressed, it'll be painful, but it shouldn't be unbearable pain. But in this VMO trigger point, a lot of the time it's unbearable pain. And that's because people don't stretch before they do stuff. They don't stretch afterwards. They don't take care of their muscles on a kind of individual basis. So if we've got a leg day, they don't do stretching. They maybe do it once a week and it has a little bit of leg flex in it. It's just not enough. Now, when I say about knee pain as well, the VMO attributes to kneecap pain as well. So if you've got a tight VMO, you can sometimes have quite a lot of pain through the kneecap, and it's not the kneecap itself that's damaged. It's not anything underlying. The other kind of pain you can get from a VMO that's slightly tight is also back of the knee pain. So that's a common one where people are like, I've got a pain at the back of my knee or slightly to the side and the back of my knee, and I can't figure it out. And most common practices will say, well, we have to look above and below the area that's painful to then ascertain what's going on. I would say, don't look above and below. It's definitely going to be the VMO if it's coming right across that back of the knee area. The other thing it could be is a hamstring, but that would flag up in other movements. So the hamstring itself would probably be painful in this kind of duality of pain, back of the knee, hamstring. But if it's just back of the knee, it's going to be that VMO again. Now, we have to also trace the VMO and where it goes. So it does run up the inner leg. There is a secondary trigger point a little bit higher up that will allow the muscle tissue that runs close to the VMO to be released as well. So again, if that's something you're interested in, trigger point therapy is definitely the way to go about finding out these kind of things. But it is very common that VMO and that diagram I put up today is the problem with a lot of knee issues. Now, I did mention that there is things like the knees falling in, knees falling out. Now, this could be due to positioning of the legs. And to really think about this, the reason knees pull in a lot of the time is because the muscles on the inside of the quad are too strong. They're too strong for the outer quad muscles to deal with, and vice versa. If the knees are buckling out, we've got outer quad muscles that are over dominant. To fix this, we basically just train the muscles to work in unison. So we don't want to have a muscle that's overpowered, because then you'll see that. We also work on feet position to see what may be better for the person and their body type. So that could be another consideration if you really want to go down that path. But for the most part, I would maybe get them starting to work on leg presses more, slowing down the movement, making sure the muscles are all having their own individual focus through the movement. And through that kind of therapy and through that kind of maybe even individual leg extensions to concentrate one leg on the other so it's not over dominant, we can then see better increases in their squats. So they will actually have no pull in. Now, there is other things you can do. So for instance, if you've got a inner quad overpowerment, you can use bands. You could band the person round the quads and ask them to push out before they start the movement. That way they will engage the muscles. But again, engaging the muscles won't always overcome the overpowerment. So are they going to do that when you're not there? That's something you'll have to consider. The next thing for the squat, and the squat's got so many factors to it, is your hips. So again, very commonly, people have tight hips from sitting down too much. You'll probably feel it yourself. If you're sitting down, lying down too much, you stand up and you're like, oh, I'm sore. This is just the muscles getting tighter because that's what they've been left to do. So what we would recommend is making sure that you have a very good warm-up for this kind of thing. Now, there's obviously other things that can go wrong. So first of all, we want to make sure that the entire hip area is fully open. So one of the things I'll do with clients, athletes, or whoever I'm working with, is I teach them how to do a deep squat with the use of the barbell itself. So on the rack, hold on to it, go up as if you would to do a normal squat, and then sit down as deep as you can. And you spend about 20 to 30 seconds just deep breathing and allowing the muscles to open up around the hip area. Now, if you don't know this, breathing techniques are actually really good for opening up muscles, and that's why we advocate it during stretching. So when they're down there, it's big, deep breaths, and these deeper breaths will allow for the muscles to then release. That's what we're looking for. And then you've got other stretches like the groiner stretch, where you can really open up the inner and outer hips depending on which way you push and pull. So that's a really good stretch. Pigeon stretches are really good as well. So once you've got those hips open, hopefully there won't be any issues. But the most common ones we get are maybe due to like piriformis syndrome, where we've got tight inner muscles of the glutes and they pull and then push on a nerve. So we don't want that kind of stuff. So again, flexibility training will usually help that kind of thing. You may see that a person's hips are misaligned. In this case, we need to look at functioning properly, or is it a case that we have to then give them more training? Usually if the hips aren't sitting quite right as they go down, that could be an indication of stronger muscles on one side pulling on the other. Sometimes we get the thing called the butt wink, where the actual glutes and hamstrings themselves overpower and then turn your hips under as you squat. So in some cases, you might get one side that's dominant more. And you'll probably find when you're standing tall that you do lean in a certain direction. And that kind of thing is what eventually leads to an overpowerment on one side. So that's a consideration we would look at. Again, if somebody does have a really tight one side on their hip, we would look at maybe manual therapy techniques, trigger point therapy, foam rolling. You've got loads of good things now like the pulse guns. We can use massage therapy if you know anybody who does that, or if you do it yourself. And cupping and kinesiology are also a couple of good ones that we can add in there that are less invasive and can really help those muscles then relax out and allow us to then get to that proper depth of a squat. We then, as I said, might have things like the butt wink that goes on. Now, we can look at reducing that. There is specific techniques to doing it. One of the things you can do is set the height and do seated squats. So if you've never done seated squats before, we put either a bench, a chair, or some boxes down. I prefer using boxes because then you can manage the height. And what we would try to get somebody to do is go as low as they can without the butt wink occurring. And we train them to that point, and then we might unload the bar slightly and see if that makes a difference and allows them to get further down. So what we tend to do is we might overload a person with weight who might not be ready for that weight, and that's why the butt wink kicks in and stops us going any further. If we slow that movement down, keep it slightly loaded, we can get further down usually, and that will elongate and further the development of the muscles. So work the person down to as low as they can go, or as low as they feel comfortable. And again, it'll be goal dependent on how much you want a person to get down on a squat. If it needs to be ass to grass to get the goals, fair enough. If it's not and you want to stop them, fair enough. It's really down to yourself. But and decreasing the butt wink, we would want to get them to go lower with slightly less load. And then we would each time challenge them to get a little bit lower through their sets rather than just saying, right, that's low enough. We would actually want to work on that flexibility, make sure they get all the way down, because most people can squat all the way down naturally. And then once you load them, that's when they stop doing it. So that's something to always look at. The next thing we might look at, and this is a kind of harder one for people to notice a lot of the time, is spinal misalignment. So you might notice it because the bar doesn't sit in a straight line parallel to the ground, but most of the time it's going to flag up on somebody who's got a really misaligned shoulder. So that means that one shoulder's dropped an awful lot more than the other. And for those kind of cases, that actually is a reflection of the spine. The spine is usually slightly misaligned. Now, that doesn't mean it's going to be anything bad, but it is something we have to consider, especially if they say they're getting pain. Again, people might complain about it being up in their neck, might be lower back. We have to look at managing that pain. And at this point, this is where we really need to think about the anatomy and physiology of a person's back, as well as just what their legs are. So in conjunction with the lower body, the back actually has a crisscross system. So it's like an X going across from each hip to the opposite shoulder. Now, if one shoulder is dropped slightly, that could mean the muscle tissue isn't as tight as it should be across the back. So they might get hip swing. They might not be able to get as deep because it feels lax. Or it could be the opposite. It could be tight. And in that case, they might get pain. So we need to ascertain which is it, and is there anything we can do to fix that? Again, manual therapy might be the way to go. Maybe decreasing of load for a while to allow the muscles to get back into kind of normal positioning. But for the most part, if it isn't bothering them, we would just leave it as be, because sometimes people have these spinal injuries, they've had it all their life, it's something that's not probably going to get fixed, i.e. like scoliosis or kyphosis, unless it's extreme and we can't do anything with it. I would just leave it as it is. Again, pain is going to be always the thing that we want to stop a person having. So there is approaches you can do for that. And I'll talk a little bit about the back muscles as we move through the other stuff, because I've spent a lot of times on squats. So I'm going to move on to the opposite end of the body and talk about the overhead press. So the overhead press is one where we can get a lot of common issues that pop up. Obviously, pressing a barbell above your head can be quite hard for some people. So we would look at things as in, are they all aligned properly? Shoulders, does the press come up properly? Does it arc? Is the push coming from the right place in the palm of the hand, which is a common one that can cause pain? Shoulder mechanics, is the shoulder moving properly? And again, sometimes you'll need to move from the back all the way to the front to see that. Or if you have use of a mirror, that's obviously great as well. We will look at things like the scapular movement on the back as well. And does the rest of the body move? So being that an overhead press is a standing movement, what else is going on with the rest of the body? Are they pushing through their toes? Do they have a good base? Are the knees loose? Are the hips tilted at all? You know, these are indications of things that could be going wrong. Again, does one arm over dominate? Like some people might feel that they've got a weak left arm or a weak right arm, but it isn't always the case that they actually have a weak arm. It's usually that they just don't have the power, they haven't developed it enough if it is weak, but most of the time it's a case of something that isn't working correctly, because we use both arms on a daily basis and they should both be as equal as they can be unless you've had a prior injury. So my first analysis when I'm watching somebody doing an overhead squat would be the scapula. Is there any kind of clicky movements that I can see? So there is fibers that run across your scapula, tendons and ligaments, and sometimes you'll see a kind of jerk when the scapula is moving through its motion, and this jerk is usually like almost like a bump, or as if it's so the scapula is a smooth surface and it's almost like it's bumped over something. That's what it'll look like when you are looking from behind on a person, and that's an indication of usually a tight muscle across the spine. And again, this could be due to a prior hip injury, prior leg injury. If their legs are feeling sore for whatever reason, we would have to examine what's going on with our client in that certain situation to see why is that occurring with the scapula. And usually that movement, if we can figure out the muscle tissue and where it's actually damaged, we can usually release that point and allow for that smooth transition of the scapula itself. So that crisscross pattern I just talked about in the squat, we would be looking right across the spine from the top of the shoulder through the scapula area into the mid back. And that's usually where we'll find there is a little bit of tightness because of whatever they've been doing prior to the session, or in the days, weeks, and months before it in their job. That's usually where you'll find that tightness. If we can get that out, then obviously that's going to help us. Other ones that usually occur is in the lower back region, usually where the spinae erectors are. That's where you usually find that they are finding a little bit of excess pain, and that can be the feeder on for the scapula not moving properly. So it's worth taking a look at these things. The more uncommon one is actually the trap is interfering with it. And sometimes you get people who have tight traps because of overuse, or they might have overtrained it. And again, that might pull on a certain element that can give you a little bit of scapular pain, but that's usually the uncommon one. Just remember that the trap is a big muscle. It's not just the side parts to your neck, and it does actually have a bigger reach in your back. So it's a good one to look at. If we're looking at maybe somebody who feels they've got a little bit of weakness through the movement, sometimes that can be due to not training their rear and lateral heads enough. So obviously the shoulder joint has 3 different parts to it. And the common way that most people train is those front delts. They'll maybe have a secondary little bit of lateral work in there, but those front delts are going to power most of the start of movements and help with the lockout at the end. Now, if a person's feeling a loss of power through these, that's where we would immediately look to, because the front delt is going to always be the stronger one, but do they have enough power in the rear delt and the lateral heads to be able to power the whole movement as one bigger compound movement? And the usual answer is no, they haven't trained them enough, especially the rear delt. That's one of the least trained areas of the shoulder joint. So that's where we would then be able to put in a plan and make sure that somebody was issued with the right training to be able to get the overhead press better and allow them to get more power in there. The secondary point to that might be the tricep muscle might not be strong enough for the movement. So again, you could do a few little bits of tests there to make sure which part should be focused on more. The most common injury type we get though with this movement is your rotator cuff. So if you've never had a rotator cuff injury, then great. Please hope to God that you never get one. but it is a very small piece of your shoulder on the inside of the shoulder that basically helps the ball and socket move about. Now, if this gets damaged, your shoulder can do all sorts of wonderful things and not in a good way. So if a client does have this, we immediately stop and we work on getting the rotator cuff rehabbed. That would be a rehab thing. And there's a lot to it, and I do have a full video on rotator cuff rehab. It's on my YouTube channel. So if you want to jump across there at any point, let me know and I'll give you the YouTube. But safe to say that the rotator cuff is something I've actually injured myself as well. And it can make your shoulder pull towards the chest. So you have that rotation inwardly, and it's not nice. It means that you get lack of movement in your shoulder. It means that your rear deltoid is actually getting elongated and pulled. The lateral head doesn't work quite as well during that kind of rehab process. So it's a really hard one to work with, especially if you've no specialization in the joint itself. So be careful with that one. But most rotator cuff injuries come when people try to overload the joint. So that's why we have to be careful about the load that we're giving somebody when they go overhead. Now, good indications of this would be if somebody has rounded shoulders. That could be an indication that their chest muscles are overpowering their shoulders, and that could essentially lead to a rotator cuff tear because there's just too much pull on the shoulder area when you do overhead stuff. So be very careful of people with rounded shoulders. Try get them back into natural posture. A good way of doing that is stomach vacuums. If you haven't heard of them, quick and easy Google search will show you what I mean there. And they are brilliant for bringing posture back, especially to people who work in desks all day. I'm kind of conscious of the time, guys. I've got 7 minutes, and what I'll do is I'll talk a little bit about deadlifting next. And then when we're coming closer to the time, we'll log off and we can log back in if we want to discuss anything else. So deadlifting, again, very complex movement, probably the most complex movement. So we are working with the rear kinetic chain, essentially, and making sure that that's strong enough to be able to lift the load. Now, this is where we have a lot of common issues, is the rear kinetic chain isn't strong enough. So we have people who have weak hamstrings, weak glutes. We have people who have weak upper back muscles. So that's where you see the flexibility of the spine not being able to be held. We also have people lifting their head, which disengages the rear kinetic chain. So first of all, we want to always make sure that our eyes are looking down when at the bar when we're starting, or depending on your positioning, your head should always just basically be looking ahead. So from the bottom of the movement all the way through it, you should always have your head kind of stick to the same point. Now, I always talk about the lollipop on, like if you look at a lollipop and you were to flex it down and flex it up again, the lollipop doesn't move, it just stays in the same place. That's how our head should be to make sure that we maintain the rear kinetic chain. Upper back. Now, a good tester for the upper back would be an overhead body weight squat. And if the arms are above the head when they do this and the arms fall forward, that usually means that the muscle tissue isn't strong enough at the back to be able to maintain any kind of sort of weight. So we wouldn't give somebody a deadlift who failed that kind of initial assessment. And that's why I indicated initial assessment's always going to be high up on the chain of stuff we do. So again, if that muscle tissue starts to round and they can't maintain the spine, it could be a case of lowering the weight. But again, my approach is always take them away from the exercise, build them back up, then take them back to the exercise. So that could be a couple of weeks of working on the back and then taking them back to that exercise to try again. The next common issue is back pain. Now, a good deadlift, you should never have back pain. Like I've lifted extreme amounts, and even before lockdown last time, I was lifting about 255 kilos, and there's no back pain. I was wearing no belt. I don't need it at this point, and I'll come to belts in a second because they are something that can cause injury. But when a person has back pain, it can usually be rooted in two things. Again, those upper back muscles not being strong enough, or the hamstring muscles not being strong enough. So those back muscles I talked about earlier on that crisscross across your upper back down to the lower back, they attach on near the hips, and then they run down to your hamstrings. They run past your glutes down to your hamstrings. Now, the glutes themselves might be tight, but most commonly it's a hamstring that doesn't have the flexibility in it for the movement. We then try to force that, and then the deadlift gives us pain. So there is a kind of chain of events that happen that means that there is going to be pain there. So again, flexibility training. Can we make sure the hamstrings are more flexible? I mean, you can do a quick test. Can they touch their toes without rounding their back? That way you could see how flexible those hamstrings are. A good way to work on the flexibility of hamstrings and still include a deadlift would be things like Romanian deadlifts, where you maybe start with the bar on a platform, take the bar from it, and then go as low as they feel they can comfortably get. Over time, that kind of training can help elongate the hamstring muscles as well as strengthen them. Should also help any kind of glute issues you have. But that should, in essence, help with the lower back pain. Now, what I'm going to do, guys, I've still got a little bit to talk about with the deadlift, but what I'm going to do now is just cut the Zoom off, and we will come back in a second if you guys are okay to do that. So just jump back on in a second, and I'll be here to finish off the part about deadlifts, and then we will talk about bent over rows slightly as well. See you all in a second, guys.